Can you hear me? Hello, everyone. Good afternoon. Hope you're going to wake up after lunch. I know I need to do some jumping jacks to get my blood flowing, but I'm Laura McDonald Stewart, and I am on the ArchLIGHT Summit Advisory Council. And I want to thank you guys, hey man, for being here. And a few things before we get started. Just wanted to say, if you have not visited our immersive experience, the impact of color and finishes, it's literally right behind this stage. So when you leave here, if you haven't seen it, go around. It's really fun because it's geared a lot towards interior designers, of which I am one, and architects. Trying to explain how much like the different temperatures of lighting makes such a huge difference on our finishes that we are specifying. And then also want to invite you to enter our showroom spectacular drawings for the chance to win some exciting prizes that you definitely want to take home. And then at 3 o'clock, right after this session, please join us at the Texas Roundup Happy Hours with ALA, Hosley, PLG, Sesco, and Texas Lighting, just right out here on the expo floor. Then, if that's not enough, at 6 p.m. to 8 p.m., we have our opening night reception that is sponsored by Kasambi. And then tomorrow, we have a whole other day of stuff kicking off 9 to 2. We've got the expo as well, if you didn't get to see everybody today. And then at noon, we're going to kick off our showroom spectacular. And that is a bunch of hospitality events at quite a few of the permanent showrooms upstairs. And that's really fun. They've got lots of fun food and drinks and prizes and stuff like that. So hopefully you can come back tomorrow if you're here today. All right, so now it is my pleasure to introduce our lovely speaker here, Tommy Nichols. He is the Business Development Director for Healthcare under Acuity Brands Lighting, specializing in behavioral health, healthcare, and pathogen reduction solutions. Tommy has grown into his role as an 11-year professional in the lighting industry, serving on the IES Healthcare Facilities Lighting Committee. His areas of expertise include behavioral health lighting, the needs of healthcare specialty spaces, pathogen reduction solutions to make people feel safer, and a dedication to developing solutions to expedite patient healing. Please welcome Tommy.
Thank you so much. I'm not a lectern boy, folks, so we're going to be flailing our arms and walking all over here. Well, thank you so much for joining us after this lunchtime, which is the perfect slot to be in. So excited to be in it. Thank you so much for the fantastic introduction. I really am excited to be able to showcase and share with you for the next hour some education around healthcare environments. Now, I've been involved in the healthcare space for a hot minute now, a little over a decade or so in some capacity. But what I really want to stress and share with this audience is there is nothing worse than listening to yourself talk for an hour. So feel free to stop me, ask questions, share what you have going on in your projects and in your history, because I want to hear about it all. I'm having a hard time hearing myself, folks, so volume good? Tell me if it changes. Thank you very much. But I want to poll the audience in this room a little bit, and we're going to do it verbally. When I use the word healthcare, what's the first type of healthcare project that comes to mind? Shout it out. Hospitals. For most folks, it is the hospital. Healthcare is so much more than just a hospital, though. And what we'll see in this presentation is it'll cover the needs of patients, caregivers, and design strategies that we should be cognizant of in places like medical office buildings, inpatient mental health treatment facilities, long-term care. But most of us do think about hospitals first because they're these big beacons of care that make up our local communities when ourselves and our family members need help. So we're going to talk about it all. We'll talk about some statistics and information from construction as well. But this presentation is around evidence-based design focusing on healthcare. Raise your hands in this room if you've heard of evidence-based design. I should have gotten those for everyone. Actually, let me ask this question too. Who does nothing but healthcare and you just love healthcare so much? Who's done some healthcare in the past, even if it's like a dental clinic, medical office? Who here's been to a healthcare facility? Healthcare is one of these construction types, right? That really impacts several of us professionally, but all of us personally. But what I really want to call out is while this is under the guise of healthcare, what we're discussing today is really translatable for any type of construction, from education to hospitality and so much more. So we're going to spend quite a bit of time today understanding the evidence-based design process as it relates and how it can impact patients, family members, caregivers like nurses and doctors, etc. But again, you can essentially replace healthcare with any type of vertical in here. We're going to take a good amount of time looking at some of the case studies as it relates to evidence-based design as well. My hopeful final little disclaimer here is that there is endless research that discusses this subject, especially as it relates to a healthcare environment. But what's very important to me is that you just don't hear a few bullet points here and go, great. I want everyone here to go out being evangelists of this subject on your designs, on your projects, and go inspire the inspirers. So I'm hoping everyone can learn some things around that as well. Oh, this is being fun. So we'll go through evidence-based design by definition itself. We'll discuss some of the design elements as well, from a circadian standpoint, from an acoustical standpoint, amongst other ones. Because yes, I am a lighting boy. We are at a lighting show, but a good design, especially from an evidence-based standpoint, takes into so much more in addition to just lighting and controls. We're also going to discuss the importance of an interdisciplinary team and interdisciplinary collaboration, why we should be doing it, and how we can hopefully keep things on a project and not get them VE'd off at the 11th hour. And we'll spend quite a bit of time talking about future trends as well. Now, I want to hear from you folks as well. Here's some of the different building types that make up our local communities. The majority of this room thought about hospitals first. So let me ask you all and shout it out. What % of total healthcare construction in the United States in the next 5 years falls into hospitals? Take a guess. Pretty close, actually. 15, 20. Come on, folks in the back. Oh, I have some evangelists here, even though everyone said hospitals first, right? 29%. Total healthcare construction in the next 5 years is inpatient care. So I do have to loop mental health treatment facilities in there too. How about this one? Residential health, long-term care, skilled nursing. What do you think? Percentage, yeah. Okay, what else? Who else? 9. In the Sunshine States, SoCal, Arizona, Texas, Florida, those numbers are more disproportionate, I guess I'll say. It's higher. Last year, Florida new construction for long-term care fell off the face of the map. And it actually dropped the numbers from 12% down to 9%. So it could be different in surrounding areas, right? I'm giving you a macro view. How about these guys on the bottom? Outpatient facilities, surgery centers, urgent cares, medical offices. And the answer is not what's left, because there's another one not discussed. 49%. About half of total healthcare construction are ambulatory care environments. And I share this because when we're thinking about designing these spaces that make up our futures, it's important to be mindful that healthcare is so much more than just a hospital. And there's some varying needs of the users of those spaces themselves. Come on. Clickers give me a fun time up here. There we go. So what is a healthcare facility? Please don't roll your eyes at this. It's an important one that we used to actually not even include until the pandemic. For the purposes of this conversation today, we are talking about brick and mortar style healthcare facilities where someone can get a better level of care than they could at their own home. This is important to level set here because especially since the pandemic, one of the biggest healthcare service trends is telehealth. 3 weeks ago, I had to go get a new eyeglass prescription. I didn't go to my optometrist. I went to my local shopping mall in New Jersey, went to a Warby Parker store where a tech took my eye measurements, and then an optometrist from Phoenix, Arizona telehealthed in and did what she needed to do. So today, we're talking about brick and mortar style healthcare facilities, not telehealth. And there are many of them. Just to level set on some definitions, especially for those in the room who aren't as comfortable and cool with healthcare vocab, Hospitals are referred to as inpatient care. It's places where people stay overnight. Some local communities, especially in this state, there's some more specialized ones as well that focus on servicing the needs of the local community. So most general hospitals focus on just treating general related services. You need to go in for 2 or 3 days, but then you have more specialized healthcare facilities as well. Women's health, veterans affairs types hospitals, so communities do have more specialized ones. From a outpatient type facility, this is a big one. Ambulatory surgery centers. Of that 49% of total healthcare construction, 33% falls into surgery centers. Think you need to go get your tonsils out and you don't need to stay overnight. That's an ambulatory surgery center. Urgent cares, medical offices seem to be popping up on every single city street corner because there's this drive, actually because of evidence-based design, that's pushing to the construction of not having to go to these big inpatient type hospitals for a few different reasons that we'll discuss. And then also, residential care facilities is what most of us will refer to in our daily vernacular as a nursing home, an assisted living facility, a skilled nursing facility. But from the IAS, the vocab word for this is residential care. Any questions so far, folks? For healthcare folks, I apologize. This is a 101 thing, but we have a broad audience in the room as well. All right. So some of the consumer needs for those vary slightly, but we'll notice some consistent themes as we look at these. In these areas, folks are looking for 2 primary things: sense of well-being and access to nature, which we will talk on quite a bit during this hour-long conversation today. Folks in hospitals have reported that they want places to go connect with nature. They want some kind of positive distraction to not make them feel like they're in this stale, sterile type healthcare facility. And nurses look for convenient areas of respite that aren't in the basement of a hospital. They want a room to go relax and recover in. Going outside of the hospital itself for outpatient type facilities, I said, there we go. Outpatient type facilities, while they might only be in there for a short period of time, they still want these areas that foster some kind of connectivity and wellness. But folks do report that they want fresh air and waiting rooms that have views of the outside, even if they're only going to be there for an hour, maybe more. We'll get it down one of these times, folks. And then residential care facilities. Folks have reported that they want inside environments where they can go connect with nature, especially in places where the climate may not allow them to go outside for a significant portion of the year. And they want this to feel like their home. They don't want it to feel like a stale, sterile type healthcare facility. So these are all reports from the users of these spaces, but there's some macro trends that we need to be mindful of as folks who can influence the design and construction of a healthcare environment. Generally speaking, while people in the United States are a little behind our counterparts in the rest of the world, folks are living longer than ever before. And there's implications on our eye as we do age that we'll touch on super shortly. But there has been this very significant shift going from these stale, sterile type healthcare environments, this plug and chug model, that towards ones that are moving towards wanting to focus on the well-being and the experience of the patient itself. We're going to talk very shortly about the business of healthcare and why that actually matters to the client, to the healthcare network, him or herself. Of course, we're talking about evidence-based design, but it is important to remember that hospitals are actually the second highest consumer of electricity after what type of project? I feel like I'm hearing some data centers, right? Data centers, only accurate in the state of California. Food processing facilities. Actually, the highest consumer per square foot, followed closely by data centers in certain states. So as we get older, there are some implications on the eye, and folks are living longer than ever before, even though folks in the United States were behind some of our colleagues in the rest of the world. Average lifespan for folks in the US is about 77 years old, and you can read the list for our friends throughout the world. So we're a little bit behind others in terms of the population, but there is this significant body of folks that is about to reach peak life expectancy. My population, don't hold it against me if you have a gripe with millennial population, is actually set to peak its maturity in the year 2033. So at about, 75 million individuals or so. So you have this pretty significant population that's reaching a very mature stage that's going to start needing more demand from a healthcare facility. And have we designed these long-term care environments to be able to be sustainable around those needs? What percentage of folks by the age of 70 will get some kind of service from a long-term care environment? 70%. So the decisions that we make now are going to impact 70% plus of us in this room, so we better do it right today. Now, there are some implications, as I mentioned, on your eye as you do reach a more mature age. By the time you reach the age of 75, only about 25% or so of light transmission actually reaches the rear of your eye, the retina of your eye, that stimulates many of our essentially functions in our body throughout the day. Your pupils also become smaller and your lens starts to thicken and get a little more yellow, which isn't allowing plenty of blue enriched light to reach the rear of our eye. This is not a full circadian presentation, folks, so just so everyone's aware, but we're gonna hit on some of the important things, especially as it relates to a healthcare standpoint. I think most of us in this room as lighting people are familiar with this, at least as a general concept. For our daytime and nighttime cycles, our cortisol production and our melatonin production, best thing we can do is have higher blue enriched wavelengths, especially during the earlier morning hours of the day, that make us feel productive. It makes us feel awake. And as we near the evening hours, we want to dim the lights down as much as we can and warm it up in tone, and not watch YouTube videos at 10 o'clock at night from your iPhone this far away from your eyes. But this is designed, and ideally this is the situation that we can do. But the best thing you can do to get access to those blue enriched wavelengths is go outside, get access to plenty of natural light. That's all fine and dandy until you're in a hospital patient room and you don't necessarily have the ability or the flexibility to go near the windows, let alone go outside. So it might be this discussion around how can we simulate those behaviors in an interior environment? Good so far, folks? That's the 101 history stuff. Thank you. I got to get those next time, folks. The evolution of the patient experience. There was this very disheartening article written a little over 10 years ago now by this author who visited 10 local hospitals up in the New York City tri-state area. After visiting those hospitals, here was her summation. If there's one universal truth about hospitals, is that they're these drab, dismal spaces, not all designed to soothe and heal. While most of us in this room who have the ability to shape the design in this space, this is unfortunately the reality, especially of what's existing in healthcare environments. And ideally, we're moving towards these more bright, cheerful style environments that have plenty of access to nature, colorful looking, cheerful looking as well. And when we start to look in the information a little bit, it's important to remember and be mindful of folks who have been in waiting rooms with plenty of access to daylight have actually perceived their wait times to be shorter than they actually are. So this looks a little better to me. Cheerful environment, plenty of views of nature, daylight coming into a space. But what are some of the data and what's some of the decisions that are driving your clients to start to want to look at this? Who in this room has heard of an HCAP score? Okay, only two. Well, that's why I have a job, because I get to teach you about it. Back in the early 2010s, there were some pretty significant advancements and adjustments to healthcare service models because of the Affordable Care Act. To back up a step, when the Affordable Care Act was launched in 2010, essentially overnight, 20 million Americans got access to insurance. And by, a few weeks after that, over 40 million Americans had access to insurance. Parts of those Affordable Care Act things started to put some significant criteria, I guess I'll mention, around money paid back from government-based programs like Medicare and Medicaid that were tied to how hospitals were performing on certain metrics. Some of them are mentioned right here. Readmissions is a big one. The times in which a patient had to come back for a comparable ailment to a healthcare facility, you started to lose money from your reimbursements if you had too many readmissions. So just to put that into practice for a second, let's say I went to a hospital and said, "Doc, my chest hurts." Doctor used to say Pre-Affordable Care Act. Great, we'll take care of you. You're on your way, bill your insurance. If I came back a second time and said, "Doc, my chest still hurts," once upon a time, doctor used to say, "No problem, we'll take care of you, bill your insurance a second time." Not after the Affordable Care Act, which this started to drive healthcare networks to saying, we're losing out on money here. We should really consider sending them to outpatient type facilities where they can service these needs. And the outpatient type facility could still bill for those services multiple times. So they were making their profit back. Other important ones that are really top of mind for healthcare clients, one too far, hospital-acquired infections. Healthcare facilities are absolutely disgusting with their hand-washing compliance statistics. We'll see it super shortly. So healthcare networks have absolutely been looking for ways to reduce hospital-acquired infection transmission rates and then also reduce patient falls. Patient falls, when a patient falls in the space, it is not reimbursed by Medicare or Medicaid. And on average, it's about $12,000 or so out of pocket for the healthcare network to pay for, that they're not getting their money back. So there's some metrics, and we'll discuss some of the evidence that exists and some of the things that healthcare networks have done to improve them. But this is a big one. How can we almost have the conversation with our client around putting in these solutions and making the investment forward to get essentially more money back from government-based programs? That's where HCAP scores come into play. HCAP scores are not new. And if you haven't heard that word, because I think there was only a couple in the room who raised their hands, sometimes folks will say patient experience surveys as well. It's an approximately 29 question survey that's sent out after a hospital visit. And it doesn't say, as much as I would like it to, "Did you love the lighting in your patient room?" It doesn't say that. It asks things like, how was your communication with your provider or your caregiver? Would you recommend this healthcare facility to another person? Based on performance of those HCAP surveys, of those patient experience scores, healthcare facilities have the ability to make more money back eventually based on how they do on their patient experience scores. So this is the thing that's important when we're educating our clients about these design strategies that we can incorporate so that they know, yes, they're making an investment day one that might be a slight premium, but down the road, this can benefit your bottom line. I will say in practice, I've run into probably too many renovation opportunities that healthcare networks have reached out to me and my team saying, my sole motive here is improving my patient experience scores. How can you do it with lighting? So, which is why I like to say, let's all get on the same page with evidence-based design and learn about it today so we can just educate the client from up front. Any questions so far, folks? This is an interesting topic right here, right? This patient experience survey, because we all have different priorities in this room, right? We are designing these healthcare facilities to maximize some kind of patient experience and caregiver effectiveness, ideally. We have many vendors in this room, myself included, who are trying to push and secure lighting and controls on projects. The client, the healthcare network, is eventually looking for ways to maximize their operating profit. And I think this helps bridge us into the conversation of some of the design tactics by which we can take. Okay? Now, what can lighting do? At a very high level, we have the ability to have task-appropriate lighting, and ideally glare-free lighting, that can put light where you need it to appropriately aid in measuring dosages of medication, chart in some kind of patient room, but also put task-appropriate lighting along walking surfaces to ideally help minimize patient falls. We'll get more into that shortly. Circadian entrainment and circadian support. We might use solutions for both caregivers and or patients to keep them feeling productive during the day and prepare them for sleep at night. reduce stress and improve therapeutic outcomes. We can use calming solution fixtures, which we'll talk on super shortly, promote positive distraction and mood, and then also give the patient choice, give the patient control over their surround. I am shocked no one has raised their hand yet to call me out on that image on the right. That's a very unrealistic style patient room in terms of meeting light levels. Most do when I'm giving this presentation in a room. Most will sit here and say, there is no way that printed image light fixture over the bed is going to meet the light levels you need. I am well aware. What this is from is actually this study that was done back in 2012 and then launched in 2013 with Clemson University down in the Southeast. And they were measuring different variables to see which ones were most able to reduce patient anxiety and improve their experience. And they went through this pilot of several different motives: visual distraction lighting, like you can see over the head. They have the projector projecting some kind of image of nature onto the wall in front of the patient. I think nowadays, since 2012, we might consider digital artwork. That's coming up super shortly in this presentation. But there have been folks who have tested and measured these variables, and we want to talk about some of that data. Okay? Oh, this clicker. Hand hygiene. This starts to break us into some of the research here, and I do want to share with folks, this is all publicly available information. This is right through, essentially online, through the Center for Health Design that we'll talk on shortly. But we wanted to pull some of the latest information as to how it can lead to improving some kind of patient experience and caregiver effectiveness. Like I touched on, hand washing compliance in the United States is vile. It's disgusting. It's really bad. If you reference the study on top, this was actually done on a project in Bangladesh that they were able to improve their hand washing compliance between 76% up to 88.5%. How did they do this? Two main variables they tested. Number one, they had senior nurses monitor the communal hand washing station and make sure that they noted it with their underlings when it wasn't being followed. They did a second strategy as well, is they almost put this like accent halo effect to put good vertical visual illumination over that hand washing statement to ideally draw someone's eye. Now, those numbers are actually pretty darn good for hand washing compliance. Up to 88.5%, that's pretty significant. Anyone have any guesses what they are in the United States? What was that? You're not wrong. A range of 40 to 60. Funny enough, the data and studies actually show ICUs are worse than traditional patient care environments. They're bad. So when you see 88.5% there, that's pretty darn good. So there have been some studies that have linked hand washing convenience, essentially going to the hand washing station, having a senior nurse or other facilities person wash over it and monitor it has shown the most successful results. But you know what? When someone's on an 11-hour shift and they're on their 15th patient in the day, those numbers are probably going to tame down. Some design considerations and things to be aware of with hand washing compliance. 50% of hospital-acquired infections can actually be reduced based on appropriate hand washing compliance. I feel like most of us in this room are pretty sensitive to washing our hands after a global pandemic. One would think it is in healthcare. Not yet. But this, I just hit a thing, didn't I? Sorry, guys. Something happened, tech friends. No, it didn't. That's okay. Infection control. So, yep. So some things that we might take into account. Having appropriate illumination to put some kind of vertical visual cue, visually intriguing graphics. Now, I will ask folks who have recently worked on a hospital, technology-based hand washing compliance. Have there been any strategies that folks have used to essentially monitor caregivers to wash their hands? Okay. There's one coming up shortly about a facility in the Southeast that actually drove hand washing compliance and monitoring pretty darn literally. They made the nurses tag their badges on the sink themselves, wash it for 20 hands, scan it again. So they very, very actively monitored hand washing compliance. The nurses did not like it, but compliance worked. It did work. How about fall prevention? There are many different strategies that we can be mindful of here, but overall, most patient falls happen on the getting out of the bed and on the transition to the patient restroom itself. Funny enough, there's actually only few studies about lighting's implication on reducing patient falls, very few. Most of the research around fall prevention has actually been, my words, no one else's, discrediting illuminated handrails that might go next to the patient bed. There's been very mixed results about them. And I'm not, use them, don't use them, but I'm saying most of the results from them have actually shown that it didn't prevent any injuries. It just changed the injury someone got when they were getting out of the bed. Most falls as well happen on the threshold. If you have a raised threshold on the way to the restroom itself, that's a big one that comes up. But from a lighting strategy standpoint, things that have worked is putting good vertical visual cue lighting around the entranceway to the restroom itself to have some kind of visual goal, some kind of indicator for that patient or user to look towards when they're on their way to the restroom. And I think a pretty common sense one from a design standpoint is considering slip resistant flooring, and strongly consider that the restroom is on the same side of the room as the bed itself is, so someone has a shorter walking distance. There's been one study as well that was actually done in a behavioral health scenario that's fairly recent. It was done 2 years ago, like towards the kind of the tail end of the pandemic, that showed that low-level nightlights in amber with proper glare control helped minimize patient falls in their new construction behavioral health inpatient compared to their last one. My absolute favorite subject that we literally have a full hour CEU around, but this isn't a full hour, biophilic design, views of nature and biophilia. I can talk endlessly about this subject, but there has been very clear, and I would say probably pioneering this conversation around biophilic design, was the study referenced in the top. Views of nature have been shown to do several things: reduce patient anxiety, expedite lengths of stay, like time in which it took patients to recover, just by having views of nature. There's many different ways that we can strategize around biophilic connectivity. By the way, biophilia, I'm just talking about seeing or experiencing nature. Fancy word for nature. Direct connectivity, I love these things. Direct connectivity might be around physically having some kind of contact with nature, touching our senses. So it might be auditory, hearing some kind of water flow. It could be visual, looking at more nature fabrics, digital artwork that simulates nature as well. These have been shown just by incorporating some of these strategies to reduce patient anxiety and expedite length of stay that it took someone to recover. The study in the middle, the second one on the list, is actually one of my favorites. I don't know how they actually were able to take quantitative measurements after a mother went through a C-section, but they did it in this study. And they did report that folks who had views of nature out of a window felt more relaxed during their C-section. I'm a stupid male, so don't worry about my opinion here, but that was expressed in that study. There was an interesting one about artificial skylights as well, that patients felt more connected to nature and they viewed the room as more lively. It helped them feel lower tension, lower anxiety. They didn't feel claustrophobic. I would say, generally speaking, there's actually a limited amount of case studies done with these artificial skylight style fixtures. There was one that was actually done pretty recently for offices, so non-healthcare, but people did report that they felt better in their space. They felt more relaxed, but then it was also measured that they made more rash decisions under the artificial skylights compared to the normal flat panel rooms. So probably some more research to do there. But this is one of those things, folks, when we're trying to connect folks with nature, there's almost different tiers by which we can take it. Some folks will put full atriums on the first floor of their hospital when weather doesn't allow for someone to go in and connect with nature. Many budgets may not allow for that. There were 2 studies done here and our friends in Oklahoma, in your state as well, for long-term care facilities, that they actually brought in a bird aviary into the nursing home. I have different views on that, but I thought that was pretty interesting. And aquariums to provide some kind of direct connectivity with nature for those in a long-term care environment. But some budgets may not allow for that. right? And someone from an infection control standpoint might have challenges with that. So there's some indirect strategies we can consider as well, like artwork of nature. It might be digital artwork to allow some kind of connectivity and choice for the patient. It could be things like more earth-like tones and earth-like fabrics in this space. This is a big one. Were there any strategies that folks, healthcare or not, have taken into account to bring nature indoors? I'd love to hear about them. And if not, maybe I just gave you some ideas. Okay, we'll keep going. Come on. There we go. Circadian systems and daylight. We are at a lighting show. I am a lighting person. I will say, generally speaking, all of us in this room, including myself, have a little better job to do with some of the research around circadian entrainment in healthcare environments. So I would say most of the research is around daylight access in this space, other than electric lighting. Most of the studies and research, from what I've seen that's publicly available, has been around intensive care units and then also nursing stations and behavioral health. Very few that I've run into around just a traditional, regular acute care patient room. So I think we can all do a little bit better with that. But I really like the third one on this list about infants, that it helped premature babies in their NICU. It helped improve their sleep and daytime wakefulness. It promoted optimal growth and development as well. Folks, what I've seen in circadian-esque lighting is giving the patient choice over the lighting color temperature and intensity has actually been measured more than just measuring someone's productivity during the day and nighttime. I would love to hear, folks, have there been any studies that anyone's been involved with in this room about circadian entrainment in healthcare? Yeah, we all have a little bit more work to do. But I think we can all settle on that access to daylight in a space is a really good thing, especially for patient recovery. There are some areas within a healthcare facility and types of healthcare projects that we might prioritize it. Memory care type facilities, I think, is a fairly common sense one for many. Places where night shift workers are spending the most amount of their time, respite areas, places like the nursing station as well. So there are some places to make said investment. Communication and privacy. This is a big one. I actually really enjoyed the first study in here that reported that lower light levels in the patient room actually drove the patient to want to self-disclose more information to their caregiver just by dimming the lights in the space. Now, from a construction type and layout of the healthcare facility, most of the research around this one is actually putting together an on-stage and off-stage style healthcare setting so that you have nurses doing his or her work down a separate hallway than the ones by which they would interact with their patients to make it a little more quiet for the patients when they're trying to recover. But other strategies that have been discussed have been around sound reducing machines inside the patient care space, and then also making sure that we're considering the use of decentralized nursing stations. Has anyone heard that word in this room? Ooh, new one. I get to teach you something. So when most of us think about a hospital, right? A traditional hospital from the 1980s, you had that pretty big centralized desk, right? That big nursing station that had the filing cabinets, horrific lighting, so we can all improve on that. Now, those desks were, I don't want to say a thing of the past, but have evolved a little bit to consider other strategies. One of those strategies might be more satellite remote desks that bring the caregiver closer to the patient. Those are called decentralized nursing stations. What's been shown in research is that nurses like them, partially like them, because it reduces the amount of steps that they need to take in order to go visit all their patients. Patients have reported that they feel like they can have more connectivity and communication with the caregiver. But on the flip side of things, nurses have also reported that they feel like they're losing their camaraderie with other healthcare staff in the space. So there's been mixed reports on them, but I would say generally speaking, they tend to be favorable. And then this is a significant one, giving the patient control or choice in their surround. Has anyone in this room heard of a pillow speaker? Students? No. Medical beds, usually supplied by the medical equipment supplier, is some kind of remote control tied to the medical bed. that medical bed remote control is called a pillow speaker that can interface with many different things inside a patient room. It could be the lighting. It could consider temperature control in the space, shade control in the space. So we're discussing this concept of giving the patient choice in their space. The word used to be giving the patient control in the environment, but we've kind of shifted more towards this connotation from an evidence-based design standpoint of giving someone, making them feel empowered over their room, giving them choice. So giving the patient exposure to daylight and choice of the artificial lighting in their surround can decrease the risk of patient disorientation, confusion, and outbursts. And then patient rooms equipped with these patient controls for the electric lighting, temperature, and shades has directly shown increased patient experience scores. That's pretty good. Healthcare networks really like that one. But this is a space that I see many different tiers of implementation. Some folks may only have the budget for that fancy remote control on the medical bed. That's giving the user some type of choice. But I would say some hospitals of the future have started to incorporate things like shade control, temperature control, choice of digital artwork in a space to make someone feel like they're empowered in the room. I know I skimmed through in SparkNotes most of that research, folks. This is all available as an external PowerPoint to reference for you all, because I think it's important that we really discuss how can we take this data that we discussed and what we didn't discuss and put it into practice. That's where this comes into play. The title of this CEU, Evidence-Based Design. By definition, for those newcomers to evidence-based design in the room, we are making decisions around the built environment using credible research, keyword there, put a little star around that one, to improve some kind of experience. That experience could be for the patient, it could be for the caregiver, it could be the family member, but we're using data and sharing what we've learned on projects with the community so that we can best design and implement a healthcare facility or other type of project that improves someone's experience in that space. Now, evidence-based design by no means is new, right? This concept has actually been informally discussed all the way back to ancient Greece. So in the 6th century, you had these healing temples where they inherently faced the patient rooms facing east to maximize their exposure to daylight, to make patients feel like they were, more exposed to natural day lengths during the day. But I would say until fairly recently, really up until the 1970s and then again in the 1990s, hospitals were seen as this sunk cost, the thing that was going to cost a healthcare network tons of money. But there's been this mind shift, especially from the Affordable Care Act, that started to incentivize process of care metrics, that the healthcare network started saying, we can make these investments and make it revenue generating. And I would say what really launched a lot of this accumulation of research started back in 1984 with this gentleman, Roger Ulrich. Has anyone heard that name? Some yes. If you are not familiar with this study, this is actually a pretty important one. That what happened here was this gentleman, Roger Ulrich, hosted a study in Pittsburgh area, Pittsburgh, Pennsylvania. They had 46 patients who were recovering from gallbladder surgery. 23 of them had views of trees, views of nature. 23 of them had views of like a brick wall, more like urban landscape. And for those who had views of nature, a few different positives came out of it. Nurses reported that they had better nursing notes, like, they felt like they were in brighter spirits. Less need for pain relieving medication. And the third one there that I may argue is probably one of the most important for the client here, their length of stay reduced. The time that it took them to recover was shortened from 8.71 days to 7.96 days. And you might go, less than a day, big whoop. Let's put some math behind it. There's over there are many hospital stays that require an inpatient overnight after an operation in the United States. The number in 2021 was 9.6 million overnight stays. So if you shorten the time that it took you to recover by that less than a day, about 3/4 of a day, and the savings would be about $2,100 per individual. Multiply those two numbers together, And you got a big old 20 billion plus number savings simply by having views of nature. A very simple, quick implementation that we can put into projects. Not even taking into account all of the other strategies that we discussed in the previous one. The reason I stress on this Roger Ulrich gentleman is because I would say that was the first time that we started putting pen to paper and documenting this research and starting to share it with others. Going past that, you have this organization called the Center for Health Design. The Center for Health Design back in 1993 was formed, and then in 2014, they created this thing called the Knowledge Repository. You can go on this website, create a free login, and you have access to plenty of information and other journals as well that your peers have shared from an evidence-based design process. There is endless information on here that you can sort through based on design outcome or implementation. So we'll go back to that shortly because that's an important one. Now, evidence-based design, rather than read you through the steps of evidence-based design, let's put this into practice for a second in this random example. Let's say you are working on a project and you are meeting with the client and they say, our number one pain point is reducing patient falls. There's going to be a laundry list of things, but for argument's sake, let's just say they're trying to reduce patient falls. You know that is their goal that you need to go figure out how to solve. So when you're going through this process, you define the goal. Fantastic. You go find resources that are relevant for how our peers have solved that challenge. Maybe folks have trialed illuminated handrails near the head wall. Maybe they've done amber LED tape lighting around the entranceway to the bathroom. Maybe they've installed slip-resistant flooring. You start to gather that information. You interpret the evidence to make sure that it's relevant for your project, because maybe that hand washing study in Bangladesh is not all that relevant for the project here in Dallas, Texas. So you make sure it's relevant for your space. Then you're going to create some concepts as well that might actually start to involve others on the design as well. This clicker is being super fun today. So we'll just talk. I don't need this. So you're going to sit here and look to make sure that information is relevant for you. This is all kind of done during the pre-design phase and that stage of the design process, which is also where what's called the interdisciplinary team is formed. This is so you are not on your own island during this design process. When you're looking at the research, you're reading the information, and you're discussing how these implementations might work from an operations standpoint. So from a healthcare project, you might start to involve infection control folks, IT folks, manufacturers and manufacturers reps, so that before you start to implement these in your design and get buy-in, you know that they may work for the efficiency of the hospital and maximize the patient experience. This interdisciplinary team, this is also kind of the cheat code when followed for mitigating VE, because also hopefully at the beginning with that interdisciplinary team, you got buy-in for folks who are likely going to be doing the physical construction. So everyone understands the importance of why these things are getting implemented. So notice as well, as we move to the design phase, we've started to carry some of these steps back, because when you're designing this structure or this space, you might realize, you know what, that implementation, putting this amber LED tape light or these illuminated handrails, it's just not gonna work. So let's go back and start to look at some of that other research that we've documented and see what other things that we can pull out of our bag of tricks. Now, this is a very important one. The design during bid and construction is involved. So we make sure that things are not VE'd off a project. And I may argue from a data sharing standpoint, the last ones is one of the most important. We're measuring and monitoring the results. So at least 6 months after the building is occupied, ideally you send in some kind of qualitative and quantitative research team and you go measure to see if what you implemented actually worked. Then you take all that information, you can report out on it at some kind of conference like we're at right now. You can share that information with other people who are designing healthcare facilities and other types of projects so that they can learn from your successes and also understand what may have went wrong on a project there. Any questions on that process, folks? Has anyone gone through an evidence-based design formal project? I'm going to ask you about it later. I'm putting you on the spot. Not quite yet. Some of the most studied areas from an evidence-based design standpoint are actually noted on the screen right here. We touched on some of these already: connectivity to nature, control and choice, social support, which might be having a dedicated area within a healthcare space, like a patient room for a family member to visit, positive distraction. I don't have this any further in this deck, but there was this really good study actually back in 2013 done by Texas Tech, in the state at least, that actually showed the benefit of those visual distraction fixtures in radiology areas. Because I think there was this tribal knowledge that existed that, hey, we look at a pretty picture, we feel calmer. But they actually measured it, and it showed that blood flow moved away from your pain receptors to your pleasure receptors. So elimination of environmental stressors. This might be making sure that you're having sound dampening properties and light fixtures and in the space to make someone feel at home. And acceptance of complementary therapies, yoga therapy, bringing puppies in to places to make people feel calmer, pretty significant adventure. But some of the things that are fairly table stakes now because of evidence-based design are these guys on the list. Talk about the patient on the left-hand side. Single patient rooms with plenty of views of nature. For a few different reasons, this one has been important. Patient feels like they have a quiet space to recover, lower hospital-acquired infections. Now, this was all cute pre-pandemic until we had all these single patient rooms in these new builds and had to slap as many beds in that room as we could. So some folks nowadays, to future-proof their space, are considering designs that are optimized for a single occupant, but to future-proof it, you can have design features built in so you could slap an extra bed in there if you need to. Dedicated spaces for family members to visit, either en suite or right next to the suite as well, have been shown to reduce recovery time. Meditation rooms and positive diversions like digital artwork and just regular artwork. Now, that's all cool for the patient. What about the caregiver? Some of the things on the right side are becoming more commonplace because of evidence-based design. Decentralized nursing stations, I think we talked about quite a bit already. Enhanced physician lounges that aren't in the basement of a hospital that no one's actually going to be able to go use. Same-handed room design. I'd love to hear about experience here. What that one means for folks who are not healthcare every day. Imagine you're a nurse and you have 12 rooms plus. And every room you walk in, the wall controller's on some kind of different side of the room. The bed's over there, the bed's over there. A mirrored room would put them back to back. A same-handed design is a copy and paste of the same layout to both maximize nurse effectiveness and time it takes to react to a patient who might be in duress or distress. And then ceiling lifts are pretty darn common practice now because it was reported from evidence-based design projects that over 40% of nurse callouts are because they threw his or her back out. Now, very briefly, as we're nearing the end of our time, folks, I did want to showcase one of my personal favorite studies that was done from an evidence-based design standpoint. Tell me if anyone in the room was involved in this project, because I talk about it all the time. This was Jacobs Medical Center in Southern California, done coming up on 10 years ago now. They really leaned into two main concepts from an evidence-based design standpoint: technology and biophilic design. From a technology standpoint, they had tablets that were used for the users to be able to control their electric lighting, but they also tied to this app that was called MyChart, that every day the nurse would be able to say, by the end of today, you have to take 50 steps. It made the patient feel like that they were in control of their care and their surrounds. Let's keep in mind this is SoCal. So they had these plenty of external healing gardens that were dedicated for different demographics. They had ones for children, they had ones for caregivers, they had ones for adults, and they had these outdoor spaces for a patient to physically go to and feel connected to nature. The more subtle thing they did here, there's this concept in biophilic design called wander, inducing mystery, almost like curvature that makes you want to go discover what's next. Look at the shape of the building. It was this curvilinear design, so it wasn't just this boring, stale, straight line hallway like we see. They induced wander and a biophilic strategy into this space. Now, if you are as passionate around these subjects as I am, I want to make sure that you have some take-homes here. The Center for Health Design can't recommend making a login for it. You can access the knowledge repository and the HERD journal, because evidence-based design, while there is a formal process you can and should follow, you might inherently just be looking for some kind of research to make data-driven decisions. This is a great starting point for you. If you couldn't tell, I'm very passionate as well about this subject, biophilic design. So there is a certification around nature connectivity as well, hosted by this fantastic woman, Nicole, 12-week course that you can go discuss all the nuances and history with nature connectivity. And, oh, my word. Nope. One more. EDAC certification. Anyone have their EDAC? Only one. I have mine too. So EDAC is a certification that you can get in around evidence-based design. You're taking a test, but you can take it in the comfort of your home, by the way. But a person with this certification is showed that they can implement and be a valued partner in an evidence-based design project, helping improve some kind of patient experience and caregiver effectiveness. Highly recommend you take a peek at it. Questions, comments? Things you want me to go back to? Please. Can I mic you? Never mind. Go for it.
Just a clarification question.
Yeah.
You said like curvilinear lines and do something called Wonder.
Wander.
Can you talk more about that?
Somewhat I can. One of us. I'm moving away from you. This is actually one that anyone had the opportunity to work on a cruise ship, like cruise ship design. Cruise ships are starting to induce this more, that putting into practice this concept that we evolved from called the Savannah hypothesis. So you had these places that you wanted to go seek shelter, but then be able to see the Savannah around you, prospect and refuge, and then go out and go chase some kind of place to go get your food, essentially, go chase an animal. So evolve from that. We've been looking for this almost like mystery that you can go hide and weave in some kind of space to feel protected. And cruise ship industries, what they've started to do on their big open decks is rather than have these straight, boring hallways, they'll actually create these curved paths outside next to the pools, and they'll put little cabanas around it to make people feel like they have a place to go sit and feel protected, but be able to view their surround. And then the curves have induced this response that you want to go discover what's next. I didn't talk about it in here, but there was a really cool project done up in Portland a few years ago that they really leaned into the walking paths for the caregivers to walk between the different buildings, and they made them winding intentionally to make someone feel like they wanted to go on the adventure, they wanted to go on the journey. Did that help a little bit? Okay. What else, folks?
Any comments or experiences from your own healthcare projects? Or even just evidence-based design projects, didn't have to be healthcare.
Yeah. And if you don't feel comfortable sharing here, I would still love to talk to you one-on-one, because I'm in a cool role that I get to see what's going on in North America, but I love your perspectives on this as well. So thank you all for coming to see us this afternoon.
Thank you, Tommy.
Thank you.